Welcome to the deep dive. If you're anything like us, you know perioperative care isn't just evolving. It's practically shape-shifting before our eyes.
It really is.
The sheer volume of new guidelines, medications, patient complexities, it can feel like a constant challenge to stay on top of it all.
Absolutely.
Today, we're diving headfirst into the fascinating, ever-evolving world of preoperative anesthesia evaluation. We're aiming to cut straight to the most impactful insights for your practice.
And to help us navigate this intricate landscape, we've pulled from some really solid sources. We're looking at a comprehensive review on geriatric patient management from the Korean Journal of Anesthesiology,
Okay.
a systematic review focusing specifically on pre-anesthesia assessment clinics, PAICs,
Right, the biggies.
and crucially, the very latest European Society of Anesthesiology and Intensive Care, the ESAIC guidelines. These cover adults undergoing elective non-cardiac surgery.
Excellent. So our mission today is pretty laser-focused. We want to extract those critical nuggets of knowledge, the things that will genuinely help you fine-tune your pre-op approach, spot those hidden risks lurking beneath the surface.
Yeah, the subtle ones.
Exactly. And ultimately ensure safer, more predictable patient journeys. Okay, let's unpack this.
So when we talk about optimizing patient care right from the start, our first line of defense has got to be the pre-anesthesia assessment clinic, the PACE. These clinics, well, they're globally recognized, really. Their fundamental role is proactively optimizing patients' medical conditions, detecting those anesthesia-related risk factors, and significantly improving overall patient outcomes. They're kind of the cornerstone of secure practice.
And the tangible benefits aren't just, theoretical ideas. They really speak volumes for what you can achieve in your practice. Studies consistently show PACEs can lead to a significant reduction in the length of hospital stay.
That's a big one.
Huge. Imagine the impact. One study, for instance, showed a mean hospital stay decrease from 6.2 down to 5.0 days. That's over a day saved.
Wow.
Which isn't just a number, right? It's a tangible difference in patient recovery, hospital flow, and your ability to serve more people efficiently. And beyond that, we're talking a sharp reduction in surgical cancellations for medical reasons.
Also critical. Those day of cancellations are tough.
They really are. One study highlighted a remarkable drop from 2.0% down to just 0.9%. That's a huge win for patient experience, prevents wasted resources, and, well, improves overall hospital efficiency.
And here's where it gets really compelling, I think. One study reported a significant reduction in mortality rates following complex orthopedic surgery. It plummeted from 6.1% down to 1.2% in patients who attended a PAC or got care in an HDU or ICU setting.
That's profound.
It really is. That's not just an improvement. It's a clear demonstration of the life-saving potential of thorough pre-assessment. And if you're thinking about the bottom line, the finances.
Always a factor.
Right. There's potential for substantial cost savings, too. One study reported over $486 in savings per patient. Another showed a significantly lower preoperative cost, a difference of $463 per patient.
Those numbers are truly impactful. But, you raised a great point earlier. We also have to acknowledge the nuances here.
Definitely. It's not always perfectly straightforward.
Right. While the benefits are compelling, some studies did show mixed results or no significant differences in things like patient anxiety or even cancellation rates in some cases. And many studies, well, they carried a high risk of bias.
That's a fair critique. It highlights the ongoing need for more rigorous, high-quality research to really understand how to implement PACs optimally. We know they're vital, but refinement is always needed.
Absolutely. And speaking of optimization, the SAA guidelines offer some clear recommendations on PAC timing, which can really guide our everyday practice.
Yes, they strongly recommend an early outpatient pre-anesthesia assessment. And the why is clear: to actively reduce those dreaded day of surgery cancellations and, like we just discussed, the overall length of hospital stay. That's a grade 1C recommendation, so it carries weight.
And I like that they lean into modern solutions too. Telemedicine and standardized questionnaires are specifically recommended. Grade 1B. The goal is improving patient accessibility and satisfaction.
Which makes so much sense. We need to meet patients where they are.
Exactly. It pushes us to embrace accessible technology in our pre-op workup.
Now, practically speaking, timing-wise, the full assessment should ideally be done before the day of surgery, preferably within about 30 days.
Okay, 30 days.
But, and this is a critical practical step, an updated comprehensive review by the attending anesthesiologist is advised within 48 hours before the surgery.
Ah, that final check-in.
Precisely. It ensures we always have the most current snapshot of the patient's condition, catching any last-minute changes.
And for those high-risk patients, the guidelines really hammer home that conducting the assessment as early as possible within that 30-day window is, well, non-negotiable.
Yeah, you need that lead time.
It gives us that crucial time needed for patient optimization, allows us to get them as fit as humanly possible for surgery, which, as we know, can make all the difference.
Couldn't agree more.
So we've seen how a well-structured piece check can be a real game changer. But let's zoom in now on a patient population that's becoming increasingly central to our surgical schedules. The geriatric patient.
A growing demographic?
Definitely. And their physiology isn't just different. It's like a dynamic puzzle that demands our deepest understanding. For me, this is where pre-op gets really interesting. What are some of the critical physiological shifts we absolutely have to account for?
You've hit on a crucial point there. And one of the most powerful tools in our arsenal for older patients is the Comprehensive Geriatric Assessment, the CGA.
Right, the CGA.
This isn't just a quick checklist, you know. It's a systematic, multi-domain evaluation. We're talking everything from comorbidities, functional status, neurocognitive function, sensory impairment, substance abuse, frailty, nutrition, and, of course, all their medications.
It's truly holistic.
It is. And there's evidence behind it. A Cochrane review focusing on hip fracture patients showed that CGA can actually reduce mortality and the need for higher levels of care post-op.
That's significant.
It is. Now, it might not be a magic bullet for all post-operative complications, like maybe major complications or delirium rates in some studies, but it's still an incredibly valuable tool for understanding the whole patient picture.
And diving deeper into specific functional assessments, two really stand out for their predictive power, don't they?
They do.
First, dependence in activities of daily living. ADLs, simple self-care tasks, bathing, dressing. If a patient is dependent here, it's a clear predictor of postoperative complications and even higher one-year mortality.
It's a powerful marker of reserve.
It really is. Think about that. Observing simple daily activities gives us such profound insight. Similarly, an unfavorable time up and go test, the TU test, is where you time them getting up, walking a short distance, turning, returning. If that's slow or difficult, it's also strongly associated with higher one-year mortality. These aren't minor things. They're significant insights into functional capacity and resilience.
And that's exactly why understanding these age-associated organ reserve declines and common comorbidities is so vital. Let's take polypharmacy, for instance.
Yes, the bane of many pre-op assessments.
Buckles, indeed. Defined as 5 or more drugs a day. It's incredibly common in older patients, and it significantly bumps up the risk of adverse drug reactions, rehospitalization, especially if their renal function is impaired.
So what's the practical takeaway?
Well, the ACS-SAGAS guidelines have a very clear one. Discontinue non-essential medications perioperatively. Just simplify where possible. And looking at some Taiwan data, just as an example, the leading comorbidities contributing to postoperative mortality were things like chronic renal failure, acute MI, and intracranial hemorrhage. Serious conditions linked often with age.
And what about cardiac reserves?
Profoundly diminishes with age. This makes elderly patients much more susceptible to those exaggerated blood pressure drops during induction. You see reductions in beta receptor responsiveness, Burr receptor dysfunction kicks in, reduced angiotensin II responsiveness. It all compounds the issue.
Right. And the lungs.
Pulmonary function also declines naturally, and even more so in smokers, obviously. Advanced age and functional dependence, remember, the ADLs and TU are reliable risk factors for postoperative pulmonary complications, PPCs.
And PPCs themselves are bad news.
Exactly. They can be an independent predictor of mortality. So these are really serious considerations that demand our attention pre-op.
Absolutely. And given these complexities, our medication choices for geriatric patients become even more critical. The sources strongly advise avoiding new benzodiazepines and meperidine, right? Especially for patients at risk of POD.
Yes, definitely steer clear if possible. Same goes for being very cautious with H1 antihistamines and strong anticholinergic drugs. They can really exacerbate cognitive issues.
But on the flip side, things like beta blockers and statins should generally be continued.
Yes, according to established guidelines, the benefits of continuing those usually outweigh the risks of stopping them perioperatively.
Okay, good clarification.
So maybe we can transition from those broader geriatric considerations to more detailed assessment tools and strategies for specific organ systems, really drill down into what the ESAG guidelines recommend.
Perfect. Let's start with cardiovascular assessment.
Okay. So the Revised Cardiac Risk Index, RCRI, is a familiar friend. It's adjusted for initial risk stratification, a good practical starting point.
And what about blood tests? Anything specific that adds predictive value?
Yes, natriuretic peptides, NPs like BNP or NT-proBNP, they're suggested as biological markers, particularly useful in high-risk patients.
Define high risk here.
We're talking RCRI greater than 2 who are undergoing high-risk surgery. NPs can really enhance our risk assessment in that group.
Got it.
Now, here's a critical point the guidelines emphasize, and one I think we sometimes overlook in practice. Caution against relying solely on subjective MITs estimates.
The how active are you question.
Exactly. Patients might tell you they're very active, but the guidelines clearly state that subjective estimates correlate poorly with measured meds. So don't hang your hat entirely on the patient's perception of their functional capacity.
Okay, that's a really important practical tip. So what should we use instead for assessing cardiac reserve, especially in those high-risk patients?
Well, the Duke Activity Status Index, the DASI questionnaire, is recommended. The idea is to combine it with natriuretic peptides for a better evaluation.
Tell us more about the DASI.
It's not just another score, it's a validated questionnaire. It assesses functional capacity across 12 common activities, everything from self-care to recreation, and a score of 34 or less is a significant red flag.
What does that flag tell us?
It tells us their functional reserve is concerningly low. It indicates higher risks for complications like myocardial injury, MI, moderate to severe complications generally, and even new disability post-op. It really paints a picture of their underlying resilience or lack thereof.
It's much more objective than just asking about activity levels. What about POCUS, point of care ultrasound?
Right, POCUS. It's definitely gaining traction. The guidelines suggest it for trained anesthesiologists in urgent or emergency surgery when cardiac concerns pop up.
So not necessarily routine.
Not routinely for elective cases based on current evidence. In urgent emergency situations, it can quickly identify abnormalities, trigger necessary consults, without delaying things unduly. But, and this is important, there's no compelling evidence right now that routine pre-op POCOS reduces morbidity in elective high-risk surgery.
So it's about targeted use, knowing when and why you're reaching for that probe.
Exactly. It's a specific tool for specific situations, not a blanket screening method for everyone electively.
Okay, moving on to airway management. We all know it's crucial, but the guidelines emphasize a truly tailored assessment, right? Not just the standard checks.
Absolutely. For a really comprehensive risk assessment, we need to think beyond just anatomical tests like Mallampati or thyromental distance.
What else should we consider?
We need to factor in the patient's physiology. Are they obese? Do they have OSA? Also, the environment we're working in, the devices available, and critically, the expertise of the individual and the team present.
Right, it's a systems approach.
It really is. Obesity, for instance, is a huge risk factor.
Right.
We need to pay particular attention to potential difficult ventilation and the possibility of needing front-of-neck access. And the stop bang questionnaire can be super helpful here as a screening tool for obstructive sleep apnea.
Which has massive implications for airway and perioperative management.
Huge.
Okay, let's talk renal function. For patients with known chronic kidney disease, CKD, what do the guidelines say?
They're quite clear. Quantify their estimated glomerular filtration rate, the EGFR, and also check for proteinuria before surgery. This is essential for properly stratifying their risk of postoperative acute kidney injury, AKI, and also for preventing worsening CKD.
Any other tests that help with AKI risk?
Interestingly, yes. Combining NT-proBNP testing, which we mentioned for cardiac risk, with the EGFR can actually add more information specifically for AKI risk. It gives a more complete picture of that cardiorenal interaction.
Fascinating link. And finally, in this systems review, coagulation disorders. Managing antithrombotics perioperatively is always that tricky balancing act, isn't it?
Oh, always. It's all about meticulously weighing the bleeding risk during surgery against the patient's personal thrombotic risk and considering the specific drug they're on. Every patient, every surgery, every drug combination is unique.
No easy answers there.
Not usually, but there are some guidelines. For example, antiplatelet therapy should generally be continued for 6 months after elective PCI and 12 months after an urgent coronary intervention.
Okay.
And patient education is crucial. They absolutely need to understand the plan for managing their antithrombotic therapy around the time of surgery.
Good communication is key.
Absolutely. And for the really complex cases, patients with hemophilia, von Willebrand disease, factor X deficiency, a coordinated multidisciplinary approach is essential. You need hematology, surgery, anesthesia, all on the same page.
Makes total sense. Let's shift gears now and talk about how some, well, more recent challenges in new pharmacology are genuinely reshaping our pre-op evaluations. These are areas where guidelines are evolving fast.
Indeed. Staying current here is paramount. Take COVID-19 infection. The latest ESAIC guidelines offer some very clear practical guidance.
Like what?
Like preoperative antigen testing is recommended only on symptomatic patients.
Okay, so no routine testing for everyone.
Exactly. It streamlines the approach considerably.
And what about imaging? Chest CTs.
Critically, chest CT is not recommended as a routine screening tool for asymptomatic patients. Again, reserving it for specific clinical indications, moving away from that blanket screening approach.
Got it. But what if a patient did have severe COVID previously?
Ah, good point. For patients with a history of severe COVID-19, especially those who needed ICU or HDU admission, a more extensive cardiorespiratory evaluation is strongly advised.
What does that involve?
Things like echocardiography, chest CT, and maybe even cardiopulmonary exercise testing, CPE. It highlights the recognition that severe infection can have potential long-term cardiorespiratory consequences we need to assess.
Right, the long COVID picture. Okay, another critical challenge. Post-operative delirium, POD. As you know, it's common, it's serious, impacts mortality, morbidity.
What's more, prevalence rates can be anywhere from 10 to 50%, depending on the patient group and the type of surgery. It's something we're constantly trying to prevent.
So the big question is, what can we actually do about it? What works?
Well, identifying risk factors is step one. Pre-existing cognitive impairment and dementia are the strongest predictors, consistently. But older age and significant preoperative resting pain are also important factors.
And in terms of interventions?
Ensuring adequate, but ideally opioid-reduced analgesia is key. The evidence on anesthesia-type GA versus regional influencing POD is a bit mixed. Some studies show benefit, others don't.
So no definitive answer there yet.
Not entirely, but there's growing evidence for multi-component interventions. This means comprehensive multidisciplinary care, getting geriatricians, pharmacists, nurses involved.
A team approach.
Exactly. Also, the judicious use of certain antipsychotics in specific situations, using BIS monitoring to guide anesthetic depth and avoid excessively deep anesthesia.
Right, avoid burst suppression if possible.
Precisely. And dexmedetomidine infusions have shown promise in reducing POD incidence in several studies. And don't underestimate the impact of geriatric consultation teams. They can significantly reduce POD by implementing these holistic, multifactorial approaches.
And crucially, this is a very practical point for your daily drug choices. Medications known to precipitate POD should be avoided or used with extreme caution in those at-risk patients.
Yes. We're talking opioids where possible, H1 antihistamines, atropines, sedative hypnotics generally, corticosteroids, and especially benzodiazepines. Being proactive with medication choices from the start is huge.
Definitely something to keep front of mind. Now, here's a really significant area that's demanding our attention lately. These newer medications, specifically GLP-1 agonists and SGLT2 inhibitors.
Oh, yes. Semaglutide, liraglutide, empagliflozin, they're everywhere now. How do they impact perioperative management? This is evolving rapidly.
So what are the current recommendations for GLP-1 agonists, the ones used for diabetes and weight loss?
Okay, for the weekly injections, like semaglutide once weekly, the recommendation is to pause them at least 1 full week before a scheduled procedure.
1 week. And if it's for obesity?
If the indication is obesity, a longer pause is recommended, 2 weeks, which is roughly 3 half-lives for some agents.
2 weeks for obesity indication. What about daily ones?
For daily oral or subcutaneous GLP-1s, the recommendation is simpler. Just pause on the day of the procedure itself.
Okay, but here's the crucial warning, and this is something you really need to etch into your mind, right?
Absolutely. This is critical. Even with appropriate pausing, there is no evidence that stopping these medications completely eliminates the risk of delayed gastric emptying.
So the takeaway is?
The takeaway is all patients taking GLP-1 agonists should be considered at risk of having a full stomach, period. Regardless of whether they report any GI symptoms like nausea or bloating, assume the risk.
Wow. So how do we mitigate that risk?
Well, a clear fluid diet for the 24 hours before any procedure requiring sedation or anesthesia is strongly encouraged. It's a vital preventative step.
24 hours clear fluids, okay.
And whenever possible, gastric ultrasound should be performed as part of your pre-op assessment. Point-of-care gastric ultrasound.
Right. And if you find significant gastric contents,
then you must counsel the patient thoroughly about the increased aspiration risk before proceeding. If the procedure is urgent and truly cannot be postponed, then rapid sequence induction and intubation, RSI, is advised. You have to be prepared for that full stomach possibility.
Okay, that's very clear guidance on GLP-1s. What about the SGLT2 inhibitors, the gliflozins?
For SGLT2 inhibitors, the main concern is euglycemic diabetic ketoacidosis, or EDKA. To reduce this risk, they should be withheld for 3 to 4 days before elective procedures.
3 to 4 days. And hydration.
Crucial. Patients taking SGLT2 inhibitors should also consume clear fluids approximately 2 hours before the procedure to maintain good hydration, which helps prevent EDKA.
And if you suspect EDKA post-op?
Be vigilant for it. Suspected in these patients if they're unwell. Blood beta-hydroxybutyrate is your go-to functional confirmatory test.
Okay, and what if, for some reason, the medication wasn't stopped in time?
Then adequate hydration is absolutely essential, especially if they've had any kind of bowel prep, which can really exacerbate dehydration and increase ketone levels. Monitor them closely.
Got it. Okay, to round out our deep dive, let's just reinforce some of those proactive steps we can take to really optimize patient success perioperatively. These aren't just recommendations, they're real opportunities to improve outcomes.
Definitely. Take frailty testing, for example. It's now recognized as an incredibly effective tool for predicting postoperative outcomes, especially useful for assessing delirium risk. This gets a strong grade 1C recommendation.
So we should be doing it more routinely. Which scale?
The clinical frailty scale is specifically recommended. It's feasible to do quickly in a clinical setting and has good predictive value.
And if you identify frailty?
If a frailty phenotype is present, the guidelines strongly suggest seeking a geriatrician's evaluation. Get the experts involved. This allows for optimization, cognitive, nutritional, managing comorbidities. And crucially, it allows us to consider delaying non-urgent surgery if appropriate to get the patient into their best possible shape first.
That really is personalized medicine in action.
It is. And the whole concept of prehabilitation is gaining serious ground now, moving from just theory into practice.
All right, prehab. What's the recommendation there?
The role of prehabilitation encompassing physical therapy and nutritional optimization should be established in non-cardiac surgery patients. That's a grade 2B recommendation. It's about building resilience before the surgical stress.
And nutrition specifically?
Nutritional support before surgery should always be considered. That gets a grade 2C. It's all part of that proactive preparation.
Makes sense. And finally, one last point. Post-operative ICU admission. What's the thinking there?
The guidelines actually recommend against routine ICU admission for patients with stable cardiac diseases undergoing elective major surgery.
Oh, interesting. So not automatic admission.
No. Instead, selective access following a multidisciplinary evaluation is deemed more appropriate. It helps us allocate those precious, finite ICU resources effectively while still maintaining patient safety. It's about getting the right patient to the right level of care at the right time.
That's a really important point about resource stewardship, too. Okay, what a deep dive this has been. We've really unpacked a huge amount.
We certainly have.
From the foundational, yet still dynamic, role of PACS, the critical nuances of comprehensive geriatric assessments, all the way to the latest guidelines on managing complex cardiovascular risks, frailty, and navigating these newer medications like GLP-1 agonists. It just makes it so clear how much our specialty demands a truly patient-centered, anticipatory approach, doesn't it?
It really does. It's so evident that preoperative assessment is far more than just ticking off boxes on a checklist. It's a dynamic, evolving, and profoundly patient-centered process. It demands our constant attention, our evolving expertise. It's all about expertly tailoring care, anticipating challenges before they happen and meticulously preparing each individual for their unique surgical journey, maximizing their functional reserve and minimizing risks every single step of the way.
So thinking about our listeners, what does this all mean for you? As you navigate your next pre-op evaluation, maybe consider not just those immediate risks, but how integrating this kind of holistic anticipatory approach.
Yeah, thinking bigger picture.
It's exactly. From embracing telemedicine to really implementing these advanced medication management strategies for GLP-1s or SGLT2, or doing that frailty assessment. How can that truly redefine the long-term outcomes for your patients? How will you use these insights to further individualized care and maybe push the boundaries of perioperative safety in your own practice?
That's the challenge, isn't it? And the opportunity, constant learning, constant improvement.
Absolutely. A fascinating field to be in right now.